Good day. I'm Dr. Tom Murtaugh of the Christ Hospital in Cincinnati, Ohio, on behalf of the International Cardio-Oncology Society. Today we present highlights of a recent webinar discussing the cardiovascular complications of CLL therapy. Our presenters today are Dr. Emily Tomasulo and Dr. Michael Fradley, who are both from the University of Pennsylvania in Philadelphia, Pennsylvania. Our presentation will involve several short segments regarding specific cardiovascular toxicities, as well as a case review and case discussion. It's not too early to start thinking about heading to the GCOS Summit, the Global Cardio-Oncology Summit, which this year will be held on October 5th through the 7th in Williamsburg, Virginia, in the United States. This meeting is always the premier meeting for cardio-oncology, and we know you'll want to be there. In the meantime, please enjoy these highlights.
So we'll jump right in with a case. So we have a 67-year-old who presents with weight loss and fatigue. Her past medical history is significant for hypertension, which she's had for 8 years, and is managed with lisinopril 10 milligrams daily. She has hyperlipidemia and is on atorvastatin 20 milligrams daily. Her family history is remarkable for premature coronary artery disease with a mother who had a myocardial infarction at age 55. Her social history, she's an elementary school teacher, cares for her elderly mother, and lives 60 miles from the Oncology Center. She's a non-smoker, no alcohol use, no illicits. Objective data, she has a performance status of 1 and is noted to have some axillary adenopathy with the largest node of 2.5 centimeters. She has palpable splenomegaly about 6 centimeters below the costal margin on the left. Blood pressure is 142/88. Heart rate's 84, regular rate and rhythm on exam. She happened to have a cardiac CT calcium score, which not all of our patients kind of walk in with, which showed a score of 186, which is a moderate plaque burden. And her clinical workup showed a lymphocytic predominant leukocytosis with a white blood cell count of 47,000, hemoglobin of 8.7, platelets 115, creatinine 1.2, LDH slightly elevated at 250, beta-2 microglobulin at 4.3, lipids remarkable for an LDL of 138, an HDL of 42, triglyceride of 165, hemoglobin A1C of 5.9% in the pre-diabetic range. Flow cytometry from peripheral blood confirmed a CLL immunophenotype, a CD5 positive, CD20 dim, CD23 positive lymphoid neoplasm. FISH showed a 17p deletion in 77% of cells, and molecular analysis showed that this patient has an IgHV unmutated. So to me, I'll just comment on the CLL, and then I'll toss this over to Dr. Fradley to comment on the cardiac risk. But when I look at this patient who has treatment-naive CLL with a 17p deletion in 77% of cells and an unmutated immunoglobulin heavy chain status, this is someone with higher risk CLL, and this is someone who I would prefer to start on a BTK inhibitor, a Bruton tyrosine kinase inhibitor. Dr. Fradley, how do you approach this patient from a cardiac standpoint?
Thanks, Emily. I think that there are quite a few risk factors here that are, not optimally controlled. And, as you and I have talked many times, this is the opportunity to work kind of collaboratively in that upfront setting to try our best to minimize risk so that the patients have the best outcomes with the BTK inhibitors that you're hoping to start. So when I look at this, some of the various risk factors that I see are hypertension. And based on that blood pressure in the office, we know that that's not optimally controlled. And I think that's a number that often can be passed. People don't look at that and get overly anxious, but the reality is it's not what we want it to be. We want those numbers to be less than 130/80. So there's an opportunity there to optimize. We also know that she's got hyperlipidemia as well as the calcium score that is elevated. And again, there's opportunity there to make sure medically she's being managed as effectively as possible. With that information and that calcium score of 186, an LDL of 138 is just not where we would want it to be. We would want that value to be significantly lower, certainly under 70, but moving more into that under 55 category. So optimizing her lipid management ahead of time is also going to be really important.
Thank you so much. It's so important to have this partnership. I showed this case to some oncology colleagues, and nobody even bat an eye at this blood pressure. We thought, like, oh, that's not bad, but really, it deserves attention. And I appreciate the discussion to really focus on that and try to optimize this prior to starting a therapy that absolutely can increase blood pressure.
And I think, one thing we learned, Emily, during some of our conversations together about this blood pressure, and I think that I would imagine most of the cardiologists in this webinar already know this, but I think it's also important to again emphasize that, certainly a one-time blood pressure that's checked in an office setting, particularly in an oncology office setting, where there are some very, potentially emotional conversations that are going to be had. We have to, also recognize that there's probably some benefit in longitudinal blood pressure monitoring outside of that clinic setting. And so checking blood pressures at home, putting people on 24-hour blood pressure monitoring can be very helpful to determine if this is truly representative of a chronic issue, or was this kind of a one-time situation because, of what the patient is about to experience. So again, I think that we all know that, but it's always good to emphasize.
I appreciate that. And really, after working with you, Mike, I've started to check lipids and A1C on my patients as part of one way to evaluate their cardiac risk. And I think some of my oncology colleagues are excited about doing that, and now we'll start. But I think it's really important. I guess one other thing that would be important to talk about is, what do you make of this family history of premature coronary artery disease? Because I'm not quite sure what I should do with that if this patient's in my clinic.
Yeah, I mean, I think it's just an additional aspect of risk. Obviously, she has a first-degree relative who developed coronary disease at a younger age. It's just one of the various risk factors that we need to consider. I wouldn't say that this is any more important than the blood pressure and the lipids. And certainly it's not something we have any ability to control, but it's data that tells us that we need to be as aggressive as possible with risk factor modification. And as a cardiologist, I want to thank you and your colleagues for checking those values, because while we've talked about the fact that we as the cardiologists should be working with you and owning the management of those conditions, having that data available to be able to make the decisions is incredibly helpful and makes those visits that much more beneficial to everybody.
There are 4 FDA-approved BTK inhibitors. 3 are covalent, which means that they bind irreversibly with the cysteine residue. Ibrutinib, which was the first in class, which was FDA-approved in CLL in 2014. Acalabrutinib, which is a second generation. Zanubrutinib, also a second generation. And then there's one non-covalent BTK inhibitor, which binds reversibly, and that's pirtobrutinib. And pirtobrutinib is effective in vitro and in vivo, even if a patient has a BTK or other type of resistance mutation that they acquire while on a covalent BTK inhibitor. Yeah, I think this is really helpful, and I guess something else that I should incorporate and encourage my hematology oncology colleagues to incorporate is I see kind of the inclusion of biomarkers here, and not strictly just relying on an echocardiogram. And so, how do you recommend, Mike, that we use biomarkers in our testing when we have patients who are on BTK inhibitors? Is that something that for every patient, or who is the patient who you would recommend that we do that in, or what? How would you guide us?
Yeah, biomarkers are I think somewhat of a controversial topic. I think that there are some people that are very committed to biomarkers, and then there's other people that are a bit more skeptical of biomarkers, because we don't have perfect data to guide our decision making. I think that where biomarkers can be most helpful is demonstrating or suggesting the possibility of an issue. And so particularly in environments where maybe resources are a little bit more limited, being able to do a blood biomarker test might be a way to suggest a patient that is potentially having problems and then would require further evaluation. I think it's just important that we don't rely on biomarkers to make diagnoses, in the majority of the settings. There are certainly circumstances where you can. I mean, if a person has got crushing chest pain and the troponins are 1,000, I think we can all agree that that's all consistent with the diagnosis of an MI with ST elevations on their EKG. But a BNP elevation, in the 300 or 400 range may be indicative of heart failure and may suggest that patient that warrants some additional workup. So I think it's just important to understand that biomarkers require a nuanced approach and that it's not an all or nothing in most cases. So I don't use them in my own practice all that frequently, but I have many, many colleagues who I, have the utmost respect and view as mentors of mine who do use biomarkers more frequently than I do. So I do think it's a little bit of a individualized practice approach, but use them, I think, to help guide further decision making. My biggest concern, I think, with biomarkers actually relates more to how we communicate those findings to patients. With patients having so much access to the primary data in their medical record, seeing something that's listed as abnormal and red on a printout is sometimes very anxiety provoking. And we all know that some of these abnormalities are not necessarily clinically significant, and we don't always have a good explanation as to why it might be abnormal. And that can lead to patients feeling frustrated, uncertain, anxious when they see something as abnormal and you can't explain why. Bleeding, hypertension, and arrhythmias are what we think about the most. There, has been some conversation around heart failure. I don't think that there is a true clear signal that BTK inhibitors lead to heart failure, although there have been some reports and some suggestions. And so I think that's certainly an interesting avenue to probably investigate in a more kind of thoughtful way. And then again, the same thing around the ischemic complications. Neither are very clear, but they may occur. And they may occur secondary to one of the other problems. So it may be that the ischemic complications are occurring because the hypertension is exacerbating the problem, or it may be that the heart failure is happening because the atrial fibrillation is uncontrolled. But these are the various toxicities, so to speak, that one might consider with the BTK inhibitors.
And Mike, just kind of for my own knowledge and for my patients, we mentioned that these BTK inhibitors can affect platelet adhesion, aggregation, function. When we start someone on a BTK inhibitor, what do we do with their aspirin, and how do you navigate that, and kind of what things would push you towards or away continuing aspirin versus stopping?
Yeah, it's a really good question, and it's always a controversial one. And I think that once again, we just have to take this very individualized approach with the patients. I think we have all recognized more and more that aspirin has often been overprescribed, but for a lot of these patients, they have often come into their CLL diagnosis with these cardiovascular risk factors that would warrant aspirin use. Certainly people who have known ischemic heart disease and who've had stents, who've had bypass surgery, that's a population that we've really got to maintain. The patients who are on it for primary prevention, there is the patient that has the calcium score of 155 that would warrant aspirin, and that would certainly be appropriate, but maybe it's not as necessary, especially if they're starting to have some, more annoying bruising issues. So I think we just have to individualize it to the patient, stop the aspirin in the people that shouldn't be taking it, honestly, whether they're on a BTK inhibitor or not. But then the ones that have an indication, we can tailor it and decide whether we need to try to manage around the aspirin and work through some of the potential bleeding and bruising complications, or are these patients that we probably can kind of take the risk of stopping aspirin because that risk is so low.
Well, that certainly was an excellent presentation with a chance to hear both oncologic and cardiovascular perspectives on the cardiovascular complications involved in treating CLL. I'm sure you enjoyed it as I did. Don't forget to plan to be in Williamsburg, Virginia, in the United States on October 5th through the 7th, 2026, for the GCOS 2026 Global Cardio-Oncology Summit. Always an outstanding meeting, and I'm sure you'll want to be there. For now, on behalf of the International Cardio-Oncology Society, this is Tom Murtaugh saying, treat cancer, protect hearts.